So, thank you for having me. I think I spoke at a similar meeting over here in Dublin, what seems a lifetime ago now, pre-pandemic. So it's nice to be back, and nice as well also hopefully to be able to show you that we've made a bit of progress in this field. So I've been asked to talk about non-motor features, and historically that's really just focused on psychiatric symptoms. But this is really now expanded, and so our spectrum now really, and the work that's going on in dystonia is far more widely spread. So yeah, we still do a lot of work on psychiatric symptoms, but we're expanding much more into looking at disturbances to sleep, the impact of pain, and also on, when we talk about cognitive function, we talk about a really high-level processing, so things like planning and organizing. And also, I mean, there are some people as well looking at the interplay between these things, because they don't happen in isolation. So I obviously can't cover all of this today, but I'm going to try and do a sort of whistle-stop tour of some of the highlights more recently from a research perspective, looking at psychiatric sleep and pain particularly in this year alone has had quite a few publications just focused on that area. But first of all, I'm going to start with some work that we did using the UK Biobank. So I'm not sure if you're familiar about this, but this is a big initiative done from the UK government and all of these funders that finished just over 10 years ago. Now, finished recruiting, but the data is publicly available, available to everyone. And their criteria was that they wanted to recruit 500,000 people, and there was no criteria over whether someone was well or not well. People were just invited to take part. So this was meant to be as close as representation of the population as they could manage. And then within this, people would go to assessment centres and they'd undergo a number of different questionnaires, tests. They'd fill some in, they'd get their medical reports, look at the drugs that they were on, and they'd then collate all this data. They took blood samples, so there's a lot of data relating to just normal like kidney function, liver function, but also DNA samples as well. And then some people also had imaging, and in this setting, particularly brain imaging. And then this was linked with their NHS data as well. So this became this huge data source that both with hospital and GP data. And then later on, they started doing all these other things, and some of this with these accelerometers. So these are wrist-worn devices, the Apple Watch or the Fitbit, and we'll come back to that in a little bit. But the advantage, so we did a study using the UK Biobank, trying to identify patients or people who'd been diagnosed with dystonia from this data set. And one of the reasons for doing that is because there's very few studies that look at all the non-motor symptoms in a single group of patients with dystonia. So often a study is set up maybe to look at sleep or maybe to look at pain, but they don't address all the other symptoms. And so in the same way that we see a lot of variability in the motor, the movement bit of dystonia, our theory, our hypothesis was that there's similar variability in the non-motor, but across the spectrum, and we wanted to get a flavour for that. So there were over 1,300 people in the UK Biobank who had a diagnosis of dystonia. So a pretty big sample by most dystonia studies. And some of the assessments that they'd undergone in order to sort of establish these the non-motor symptoms then. So the psychiatric ones, we had all the data from the hospital and the GPs, but they'd also done some specific questionnaires, mainly around things like anxiety and depression, but also more widely sort of eating disorders, post-traumatic stress disorder, questions that were wider than, that we would normally do in a study. The pain bit of the study of the UK Biobank was actually not as good as you might hope for. So there were only a few pain questions, and it was essentially yes, no, do you have pain? That was it. And then you had to identify the body region that the pain affected. So there was no grading of, like, the pain was more in the neck than the leg or anything like that. So it was quite a crude measure, actually, on from that perspective. The sleep questions, again, were pretty basic, and they were aimed to pick up things like insomnia, whether people snored a lot, so whether they had sleep apnea, so very generic sleep information. And then everyone got given a sleep score, dependent on how you scored on these questions. And then last of all, the cognition tests were pretty extensive, and cognition is very It's very hard to do well in a study because there are so many tests that you can do. The only downside of the biobank is actually the number of people who are willing to do all the cognitive tests as the study went on started to drop off. So the actual number of people that we had from the Dystonia group who'd done the cognitive tests were quite small. But in terms of giving us an overall flavour of the pattern of these symptoms, when we took, this is the whole Dystonia cohort, so this is about 1,300 people, and the detail here is less important, but the blue bars are the psychiatric symptoms, and the green are pain, the purple is sleep, and the pinky colour are the cognitive symptoms. And if it's got a red margin, it means that there was a substantially higher level of these symptoms in the Dystonia group compared to control group. So overall, we're seeing that actually the psychiatric and the pain symptoms were the biggest or the most prominent and quite spread across the whole cohort. But actually there was quite a lot of sleep, and really there hasn't been much sleep research really in Dystonia. And the cognitive problems, although less than the others, were quite specific and quite isolated to particular types of cognitive function. But then one way that this study helped us was we could break down this whole Dystonia cohort into different sorts of dystonia. So when we looked at cervical dystonia, so neck dystonia, you start to see that there's different pattern emerging. So again, the psychiatric symptoms were particularly prominent, across the board. And in that blue category, there are things like anxiety and depression and PTSD as well. But then the pain became much more localized. So whereas before it was very sort of global pain in the overall cohort, in the cervical dystonia cohort, very much neck, shoulders, as you would expect, because the dystonia is affecting that area. And then sleep was less prominent and very little cognitive disturbance. But then if you compared that then to blepharospasm, overall, the picture was a lot less compared to cervical dystonia. So it seemed, at least from this study, that the sort of spectrum and the intensity of the non-motor symptoms are not only different in blepharospasm, but are slightly more constrained than we see in cervical dystonia. And then the last group are dystonic tremor. So these are people who have dystonia and tremor together. And you see here, this is much more like the overall cohort. So sleep is much more of a problem here. And sort of when I relate that back to clinic, often we see people who have dystonic head tremor, so their head nods side to side or forward. They often describe disturbance to their sleep. They find it difficult to go to sleep at night because of the movement in their head. So for us, this sort of really reinforced our views that the non-motor symptoms are not this just one size fits all for everybody, and that when we're looking forward in terms of how we're going to do studies, and more importantly treatments as well, that really we need to be tailoring it to different forms of dystonia. And that sort of led into another study so a lot of this work was done during lockdown, but another study that we'd set up actually before lockdown. So the psychiatric symptoms, and particularly anxiety, have been a long interest of mine. And one of the issues around treating anxiety and dystonia is a lot of the drugs that people might get from their family doctor, their GP, to treat anxiety or depression. There's always some anxiety that could make the dystonia worse, because there is some literature to support that. And so I've always been quite interested in, could we look at other non-tablet therapies that might be effective in managing the symptoms of anxiety and dystonia? So colleagues of mine in Cardiff do a lot of work on military post-traumatic stress disorder, and so they've developed lots of models for managing that. And one of the things that they've done work with is an online cognitive behavioral therapy program. So a sort of a multi-week program where the patient can log in and do the session for that week while also keeping a diary and that sort of thing. So these programs are now quite well established, and in fact we worked with a company based over here in Dublin to do this, called Silver Cloud. And this first phase of the study was just to see whether this was a feasible approach to trying to manage some of the psychiatric symptoms. And so this was an 8-week program. And I had a research assistant who was, the funding was to pay for her to do this, but she was not a clinician. And so the initial plan had been that the patients were going to do this at home by themselves, and then she was going to go and visit them every couple of months and do some questionnaires face-to-face and video them and all of this. And then lockdown came, and obviously we couldn't do this. So we had to change this study to a completely virtual study, which actually has transpired is good because we've shown that we could do this over a huge geographical region if we were to take this forward. And so she would do all the intro sessions via Zoom, set people up on the program, show them how to use it. It's very user-friendly, but essentially there's 8 modules. You do 1 module per week, and then it addresses different components, and this is specifically designed for anxiety or depression. So cognitive behavioral therapy is essentially looking at, we have these scenarios in our life, we can't get past, anxiety and depression affects everybody, but it's about how we manage those symptoms and what techniques can we put in place so that when we're confronted with something difficult, how can we better manage that? And in the context of dystonia, not only manage that from the anxiety symptoms, but also from the movement symptoms as well. And then alongside this, there was a diary where people could fill it in if they wanted to reflect on how they were getting on. And then we assess people at 3 months and then at 6 months after they'd completed the program. And so this was at feasibility. So this was just to see whether people engaged with it and whether they would do it. And the program let us see how many times people logged in. So we had about 70% engagements. And the people who did engage well, in at least 7 of the 8 modules, said that they would do this again. There were only 10 people in that group, but we also had 10 people who didn't do the CBT program. And then when we looked at, these are overall depression scores, so this is just one questionnaire, but the purple line are the people who had the CBT, and the yellow line are the people who didn't have the CBT, and these are people with cervical dystonia. And this is during lockdown, so I think everybody's anxiety and depression levels were pretty high here. But you can see actually at 6 months after doing the CBT, the people who'd had the CBT, that not only were their depression scores lower, but they were staying lower, whereas the people who didn't have the CBT, they were increasing a little bit. Again, for anxiety levels, I know the cohort, the purple line, they overall had lower levels of anxiety, but actually they decreased with the program. So particularly at 3 months after completed programs, this would be sort of 4 weeks after finishing the final module, they had lower levels of anxiety, and those stayed, because that's the other issue, is we can do these programs, but are they effective only for the 8 or 10 weeks that the program happens, or can we keep those effects going for a longer period of time? So this has formed a foundation. So we're in the process of going through a grant application. We're in the final stages to try and move this onto a pilot study to much bigger, so 50 people rather than 20. And we're introducing now in the next step a psychologist to help guide people, because that was one of the feedbacks we had, that although the program was great, people didn't know how to make the most of it. And so we've got part of the new protocol is for a psychologist to call twice during the program just to help people and guide people as to how best to use it. And what we've seen with the PTSD, the military stuff in Cardiff, is that actually that keeps people engaged for much longer, and people get much more out of the program in terms of managing their symptoms. And I'll come back at the end as to why I think this work's important. So the next bit I was going to do is sleep. So I feel this is this for me is my story of lockdown, because this was the focus of everything that we did during lockdown. But we had this study planned for sleep, because we have these great sleep laboratories in Cardiff, and they're brand new, and everyone was very excited that we were going to be able to use them for dystonia, and we were all set up, and it was a lot of money put in, because we were going to have to convince people to come in and stay overnight, and we'd have to have the staff overnight, and we were all set up. But because they're sleep laboratories, they've got no windows, no ventilation to the outside world, and so not only did lockdown make this impossible, but even afterwards, when everyone was looking at mask wearing and ventilation of rooms, we couldn't use the sleep laboratories at all. So we looked at alternatives, and so we used these accelerometers, so I imagine quite a few of you have probably got an Apple Watch or a Garmin or a Fitbit or something like that, and all of these devices, well, even your mobile phones, have got within them, they're able to measure acceleration in 3 planes, so at right angles to each other. And there's been a lot of work in developing tools that allow you to interpret that into human movement. So our protocol was, it was a Garmin Fitbit, so just a device that looked like this. This is a basic model, so I think you can buy it off the shelves for, I think it's like £40 now. One of the problems we had is the battery life is not that long on it, so in a perfect study, you'd have people wearing these continuously, but for ours, people had to take them off and charge them for about 4 hours each day. But alongside this, so they would wear that Fitbit for 7 days, so seven consecutive days. And we developed an app to go alongside it, because obviously, again, we wanted to capture this data. And so we could do all these questionnaires on the app. And we had to do some of the sort of standard sleep stuff. And actually what emerged was a lot of sleep questionnaires that, they're not set up for dystonia at all. They're set up for sleep apnea, or for people who have very severe insomnia. But anyway, we had to use these, and then people would then get an alert every day just to complete some basics. So a Likert scale, so that's just a sort of 0 to 10, and you had to score on it how good was the sleep the night before, with 10 being terrible and 0 being good, what people's pain levels were like that day, and whether they were feeling anxious or not. We also asked people to fill in sleep diaries. So this is when, and I don't think I could do this, to recall when you fell asleep, what time you fell asleep the night before, and then what time you woke up. I think I could maybe do the wake up, but I don't think I could ever remember what time I went to sleep the night before. So anyway, so we did this, and we captured this data over 7 days, and then we used the accelerometer data using machine learning algorithms to try and break down different stages of sleep. And actually, sleep is broken down into multiple stages, and we have multiple cycles of sleep during the night. And so often the deeper you go down on this is the deeper your sleep, and the closer to the top is the more awake you are. So often if we're disturbed by a noise outside in the house, it's often that we're in the lighter stages of sleep, and that's why it's more easy for us to wake up. And we're most grumpy if somebody wakes us up when we come from a deep stage of sleep than if we're woken up from a light stage of sleep. But these stages of sleep are really important in terms of understanding whether there's changes to sleep structure. And if we look at other movement disorders, so things like Parkinson's disease, they've done a lot of work trying to understand changes to sleep structure, but none of this work really in dystonia. And so we were capturing all of this data, and actually the things that we found was the stuff that we were getting from the accelerometer compared to what people put down in the app in terms of remembering what time they went to sleep, when they woke up, if they had good sleep, bad sleep. Those didn't link at all, so showing to us that actually all of us are really terrible at judging, out the quality of our own sleep. But we found that actually patients with cervical dystonia, so neck dystonia again, tended to sleep longer overall per night than people without dystonia. And actually, the stage of sleep that was most affected was actually this non-REM sleep. So REM is rapid eye movement sleep, so that's a stage of sleep where our bodies can be quite active, but the non-REM sleep is when we're much stiller, so our bodies are almost paralyzed during that to stop us acting out our dreams. And actually it was this non-REM stage that was longer in people with dystonia compared to people without. When we looked at other factors, such as did people wake more often during the night or anything like that, we didn't find any differences. But this is quite important in terms of if people are reporting sleep difficulties and we're going to try and manage sleep, we need to understand the bits that are different. And the advantage of this type of study is actually the reality of getting people into sleep labs. I mean, I don't know how many of you would be willing to go into sleep lab, but it is, you come in and you have to have all these electrodes attached to your head, you have to have a heart monitor on, you're sleeping in an unfamiliar bed, often a single bed, in a university environment. So people don't often sleep normally in that setting anyway, and you just do one night at a time. Whereas this way of using the accelerometers means that we can reach a much bigger group of people. We can do many more nights. People do it in their own bed, in their own home. So we get a much more realistic picture of what people are experiencing. So again, we're trying to roll this out to a much bigger scale to try and better understand the sleep. And not just us, but other groups as well. And then last of all, pain. So we in Cardiff really haven't done much work on pain, but there have been 2 big publications already this year, and the meeting that I've just come from, there's been a lot of discussion around pain. And one of the things relates to how we measure pain, because pain, we'll never know someone else's pain. Like, I know what my pain feels like, and I can ask someone to describe their pain, but I'm never going to know exactly what their pain feels like. And so trying to get tools that allow us to measure and compare pain between different people is very tricky. And so, again, a lot of pain questionnaires, generic, not dystonia specific, just generic pain questionnaires, don't really capture dystonia pain particularly well. So this is one group who've looked at wanting to know whether the pain relates to the dystonia, so in the same area of the dystonia, or whether the pain is in another body part, and then whether or not the pain is aggravated by dystonia or whether it's completely unrelated to the activity of the dystonia. And then the various scales that they use to, I suspect people are probably sick of, on a scale of 1 to 10, tell me how bad your pain is today. But it is quite a useful score. And then how often it comes, and then what it stops people from doing. So does it impact on people's daily living? And their whole system generates a score out of 90. And okay, it's not perfect, but it does allow us some way of comparing for an individual person between appointments. Is the pain getting worse? Is the pain getting better? Does it go up and down quite a lot? The other group of people, a colleague of mine from Canada, they've done a much more in-depth questionnaire, and this probably doesn't project that well, but essentially the bit on the left points to individual body regions, and so you're basically being asked how often the pain's there, again, how bad is it, virtually on a scale of 0 to 10, how many hours a day are you affected by the pain, do you get any relief from the pain? And then they go on to want to know about what it stops, what pain stops, how does the pain affect people? So what does it stop them from doing? And then also what other factors do people feel influence the pain? So factors outside of the dystonia that might influence the pain. So this is a much more involved study, again giving a similar score out of 90. But a lot of these questionnaires, it takes a lot of work to develop a questionnaire, but a lot of these questionnaires are being developed to try and bring into clinics so that we've got ways of measuring these symptoms. And then the reason that, I think all of this is important is because if you look at other movement disorders, most other movement disorders, you can, as a clinician then, you can go to a website and there's a care pathway. There's a very clear care pathway as to what you should be offering at what time, how you should be measuring that, and what your MDT, your multidisciplinary team should be doing, what your specialist nurses should be doing, all of that. And we don't have that for dystonia. Nowhere is there a care pathway, a clearly spelt out care pathway that covers both the movement, the motor and the non-motor symptoms. And Connor's kindly taxiing me quickly back to the big meeting over the other side of town, because we've got a workshop and we've got a working group to try and develop care pathways that specifically address motor and non-motor pathways in dystonia. So this is currently what we do in Cardiff. So we have diagnostic clinics, so people who are referred, does this person have dystonia? So they come and see me, and we do the sort of routine clinic appointment, ask you about, how many, do you smoke, do you drink, all of that, what happens in your family. And then we do some baseline assessments, so we'll do a head scan, we'll do some blood tests, we may do some genetic tests, and that's really the only point of doing a lot of testing at that point. And then people go into our Botox, our neurotoxin clinic, and they get seen within that, and then they come every 12 weeks for some injections. We have quite a few specialist nurses who they do the majority of the injecting to make sure that we can see everybody within the 12-week cycle. And people just sit in this cycle, and we don't really, very rarely do we ask about the non-motor symptoms. We don't systematically screen for them in case they change. So unless the person's bringing it up themselves in clinic, we don't routinely ask about them. And then actually coming out of the nurse-led clinic, it's only if there's a problem as such, so people are not responding well to their treatment, then they come back and see one of us consultants, or we think about something like deep brain stimulation. So this is not an ideal model of care, and we should be doing better. So that's one of the non-motor working group within the international community, is that we're trying to develop something that we can do in clinic, so it doesn't, your appointment doesn't go from being 15 minutes to 2 hours. We don't want to do that, but we want something that really addresses the whole spectrum of dystonia. So I was just going to finish there. This is the team who've done most of the work, and most of them hate me because we have a half marathon in Cardiff every year. So I get the whole team to run every year, whether they want to run or not, to raise money for Dystonia UK. But thank you very much for your time.
Thank you for that amazing talk. I suspect there may be some questions. I just even know from talking to people before that there are going to be a lot of non-motor questions for you. I might start while the microphone's going around and just say, I think you probably know the answer to this question, but in your experience, do you think that the non-motor aspects of dystonia are a much greater source of disability for patients than the motor aspects, or do you think they're equal, or?
So I think our work shows that actually, it's very variable. And so I think currently our model is that we assume that the motor symptoms are causing the most problem or the most severe. And actually, in some people, actually, non-motor symptoms cause more problems than actually the motor symptoms. So I think there's this, this heterogeneity, this variability within patient cohorts, the same as any other disorder. And I think that's what's important to us, is that we need a care package that reflects that.
You hinted at the fact that we are probably under-recognizing and under-asking about non-motor symptoms in the clinic. What's your feeling, even outside of the work that you're doing, how could we do this better? Because I think most people feel they don't do it well. What could we do at the clinic level?
So I think this is one of the things we've been looking at, and one of the persistent topic that's come up is using a screening tool. So like a series of questions to go through that covers all of the aspects, all the different non-motor aspects that we've talked about, but very quick sort of yes, no, to help guide the conversation. Because, you don't want a long conversation about sleep disturbance if you think your sleep's pretty good, but you've got a lot of pain. You want to focus on the pain. So we need a system that we can quickly screen across the board to see, okay, where are the main problem areas, and how, let's spend a bit longer talking about those or looking at what the problem may be there. So I think, there's always a question then, can we do these in advance of clinic so that we've got that information so we're a bit more efficient in the clinic appointment? And then the big question is after that, okay, we can do a screening tool, but what are we going to do with the answers? We need, what's the standard model of care if someone's got a lot of pain? How are we going to manage that?
Are there any questions in the audience? Oh, it's not working. There we go. It's going around. I might ask just one more quick question. We hinted this at the International Symposium that you said everyone's pain is different. Is your feeling that there are different types of pain in dystonia, and how do we start learning about them so that we can treat them optimally? So
the people recruited to our bigger study, one of the pain questions in our questionnaire are pictures of pain, as in, and they're literally just lines on a page. So does your pain go up and down like this? Does it go up during the day and stay up? Does it start bad and get better? And it's trying to understand those different pain profiles. Now that doesn't ask anything about the nature of the pain. So is it more like cramp? Is it sharp pain? And, pain is a very complex thing. And, we found at the conference a lot of evidence pointing at the electrophysiological data of pain is very different between people, but it's how we do that that allows us to measure it in a meaningful way.
Yeah. Thanks so much. It was a very interesting presentation. I have several questions, but I'm conscious of time, so I'm just going to limit it to one. I would be involved in an organisation called the Neurology Support Centre, which is based in Sligo in the northwest of Ireland. So I would co-facilitate with a trained therapist a movement disorder peer support group weekly. And that would have people with dystonia, multiple system atrophy, Parkinson's, just for an example. But one thing that comes across time and time again, similar to my own personal circumstances, is the non-motor element of a neurological movement disorder. And the one that I pull out as the main one is anxiety. And this chicken and egg in relation to how much anxiety is making your movement disorder worse, or how your movement disorder is making you more anxious. So I was just wondering, has there been any studies done to get people's feedback or opinion with lived experience on that question? Do they feel that it's their neurological movement disorder that's causing their anxiety, or is it the other way, that because they're anxious, their movement is being affected? Thanks.
So there certainly hasn't been a study that's really asked about lived experience in that field. And one of the things is actually we're quite interested in the onset of symptoms. So are there people with dystonia who've had symptoms of anxiety or depression before their dystonia has emerged, before they've got their diagnosis of dystonia. And often when you ask people to try and remember, particularly if someone's been in the care system for 20 years, what was the exact sequence of events? It's, I can't remember what I had for supper last night. It's quite tricky. So one way that we try to overcome this, in Wales, we have a data bank that links everybody who's got an NHS number with their GP and their hospital records. And it goes back to early 1990s. So we took 24-year period and then looked at the pattern, the sequence of when someone had a diagnosis. So this is their GP recording a diagnosis of anxiety or depression up against their movement, their dystonia diagnosis. And we found actually, particularly in cervical dystonia, that the anxiety symptoms often predated the movement symptoms. And actually, when you look at the data, once the dystonia diagnosis was made, you didn't see a big uplift in the anxiety diagnoses. It stayed the same or it went down a little. That's in terms of just making a diagnosis, not the severity of the symptoms. But actually, we think that a lot of these symptoms predate the movement disorder starting.
Thank you.
Hi, I'm Steve. I've had DBS, which I believed it solved all the motor symptoms. But since I've had DBS, I've developed sleeping issues, insomnia and disorders. And now it's chronic. I wake up at 3 in the third hour every night. I don't think I'm quite in REM sleep. And I can't get back to sleep. I doze. The peculiar thing is I don't have tiredness in the daytime. It affects my energy. It affects my strength. So I worry, because I'm not entering REM sleep, I worry about issues in years ahead in cardiac, with Alzheimer's, etc., etc. Is there a link between the DBS and sleeping issues?
So the DBS studies, obviously when they were setting up the DBS, first of all just looked at the movement scores and whether they improved after DBS. A lot of those longer studies now include anxiety and depression scales as well, because people with very severe psychiatric symptoms might not always be the best candidates for DBS. But I'm not aware of any DBS study that's included a sleep measure, all the way along to see what impact the DBS has had on that. But this leads back to when we look at dystonia in its entirety, we should be looking at all of these measures in advance of intervening. Yeah.
Now, I do know that it feeds into the anxiety.
Yeah.
So because you're worried about the future and not sleeping.
Yeah.
And I would see myself, besides my dystonia, being quite healthy, but I find I get more and more anxious, and I've been in the sleep clinic in Vincent's, but the thing about the sleep clinic is, as you rightly said there, it's a peculiar experience. It's a single bed, you're all wired up. It's one night, and you're hoping I don't sleep tonight. You're hoping to try to replicate your home scenario, which I think I did, but I'm I feel I reached a holy grail here today. I love that you've made the link between non-motor and motor symptoms in dystonia, whereas before, up until now, it was all motor. And if you solve the motor or you help the motor, you've solved the issue. No, I don't agree. I think the non-motor issues are as big. I think you hit the nail on the head. And I thank you for that.
Thank you.
One more question.
Yeah.
Hi, mine's more of a comment than a question, really. I live in England and I'm part of the UK Biobank exercise. And when I was first screened, which I think was possibly 15 years ago, dystonia wasn't on the list of conditions. So I'm interested in how you've identified the patients with dystonia.
So we identified the biobank patients through their NHS records. So the biobank linked them to, so even though your diagnosis of dystonia may come from a neurologist, when the letter goes back to the GP, they input a code as well as the hospital inputting a code. And so we pull the codes rather than somebody declaring that they've got dystonia, because it's considered a more accurate way of doing it.
Ah, yes, I understand now how you got that. And I have to say I'm absolutely over the moon that you're using that data to do further research into dystonia. So thank you for that.
That's all right, no problem.
I have time for 2 more
We have a
questions, if
question
that's
here.
okay. And then we'll...
Sorry, earlier on, Michelle's my name, you said about the psychiatric symptoms and medication can sometimes make the symptoms worse. Are you finding that some of the medication or, some of the different drugs
Yeah.
versus, like for some people, obviously, coming off medication wouldn't be the obvious suitable, and CBT is great, but would it be better that other medication would be tried, because there are some that trigger the symptoms worse?
So I think in terms of medication, there hasn't been like a full-on study looking at which medication better or worse than others. I think it's not necessarily, actually, there are odd case reports that show that antidepressants or anti-anxiety drugs might drive dystonia, but they're only like one case at a time. But the problem is people like us become very anxious then about prescribing it, and should we prescribe it? Now, my feeling is that we probably should use antidepressants and anti-anxiety drugs much more often than we do in clinic. But, there is a wider pool of clinicians and GPs as well who you need to convince that that's safe to do so. So again, another bit of work that we want to look at is just looking at the number of people with dystonia who are taking an antidepressant or anti-anxiety medication, just that, the GP started it or whoever because of their symptoms. And then we need to look at the type of those drugs to get a feel for whether one drug is being prescribed more than other. I don't think we don't need to go back and do big clinical trials, because we know that these drugs are safe to use generally in the population. But I think we can have quite a big impact relatively quickly in being able to try and identify which drugs we would recommend, say, for example, in neck dystonia or something like that. But it's an important point, I agree.
One last question and then...
Hi, thanks for the interesting talk. Stephen's my name. I think you made it in the first question that you found that the anxiety sometimes preceded some of the movement disorder symptoms, and often went down after a diagnosis of the dystonia. I'm just wondering, is there any data out there that looks at situations in groups where the movement disorder started first, and that looks at the level or the severity of psychiatric symptoms following the symptom onset of the movement disorder, and following the level of the psychiatric symptoms up to the point of diagnosis, and then following diagnosis as well?
So I think, these studies are very hard because we only come across people when they have the motor diagnosis. That's what gets people referred to our clinic. And trying to pick up people in what we refer to as the prodromal phase, so the bit before the motor diagnosis starts, we've got no markers, for that. So when we, in terms of capturing severity of symptoms, we only can really measure that from the point of motor diagnosis onwards, because that's when we meet people. We have a study where we send out the same set of questionnaires every year to all the people that are recruited to try and look at change over time. And actually what we see is that there is some variation across, anxiety and depression, but it tends to fluctuate around a common line. Like, you can usually draw a straight line between the different years. Now, we've only been doing that for 3-4 years, so we haven't got 10 years worth of data there. But I think we're hopefully going to join up with the Dublin team and try and make that much bigger and try and get a better idea of over time how these things change.
Thank you.
We have no more time for questions now, but we'll have a question and answer session later on. We'll be able to address some things. I'd like to thank Professor Peall again for a wonderful talk.